Good morning, and thank you for joining us for today's webinar. My name is Brooke Thomson, and I'm the Executive Vice President of Government Affairs at Associated Industries of Massachusetts. I will be moderating today's webinar. We're thrilled to have our three experts who will be discussing the medical, legal, and political implications of the COVID-19 vaccination. Topics will include the basics of vaccine development, how developing a vaccine for COVID-19 differs from traditional vaccine development, and what actions can be taken now and in the coming months to ensure that our supply chain is ready to manufacture millions of doses of a vaccine. Today's discussion is timely given that just last week, the Baker administration announced allocation and distribution plans for the first round of COVID vaccine shipments to Massachusetts. The state's first shipments of the Pfizer vaccine have arrived and will be delivered directly to hospitals and the Department of Public Health. And what is a truly historic event, the first vaccinations of U.S. healthcare workers began yesterday, and many of us were able to see them live on television. Before we get started today, I'd like to review a few housekeeping items. We will not be doing a live Q&A for this webinar. If you have questions that you would like us to respond to, you can submit them via the question pane to the right-hand side of your screen. Go into the question pane and type your questions or comments into the window and click send. If you're having any technical issues today during the presentation, please email Sarah, and I'm going to give you her email now. It's srutkowski@aimnet.org. Lastly, we're going to cover a lot of information in the next 60 minutes. Following today's webinar, if you have any questions, AIM members can call the AIM hotline or a member of my team. If you're not a member and you're joining us today and you have questions, we have a special introductory membership that we can offer you, so please reach out. So with that, I'm going to go directly to introducing our panelists. I want to take a moment to do this briefly. Please note that I am really condensing our panelists' resumes, as I would like to leave as much time as possible for them to speak and answer all of your questions. Speaking first today will be Dr. Michael Collins, MD. Dr. Collins is a tenured professor of population and quantitative health sciences and medicine and was appointed Chancellor of the University of Massachusetts Medical School in 2008 after serving as interim capacity from June 2007 to September 2008. Dr. Collins' interim appointment also coincided with his being named as the Senior Vice President for Health Sciences for the University of Massachusetts, which at the time was a newly established system-wide position. As the Senior Vice President, Dr. Collins has spearheaded 2 5-campus life sciences strategic planning processes and continues to guide the strategic direction of the university's life and health sciences portfolio. Following Dr. Collins will be Commissioner Kevin Cranston. Kevin Cranston is Assistant Commissioner and Director of the Bureau of Infectious Disease and Laboratory Sciences at the Massachusetts Department of Public Health. Kevin does research in public health with a focus on infectious disease, sexually transmitted infections, health equity, and the intersection of substance use disorder and infectious illness. And we are thrilled that also joining us today is Maura McLaughlin. Maura is an employment law partner at Morgan, Brown & Joy. She advises clients on important hiring, discipline, and termination decisions. She also provides practical guidance in connection with the Massachusetts Paid Family and Medical Leave Act, the Family and Medical Leave Act, and other state and federal leave laws that help employers manage leaves of absence. Maura is also a member of AIM's COVID-19 task force for the past 10 months. She brings the knowledge of those discussions and will provide an important employer perspective on the impacts of the vaccine. Thank you to our panelists for being here today. And with that, I'm going to turn the floor over to Dr. Collins to give an overview of the science behind the vaccine. Dr. Collins.
Thank you, Brooke. Good morning, everyone. It's a privilege to participate in today's panel at a really extraordinary time for science when you think about it, that what's been accomplished over the course of the pandemic is really quite extraordinary. Let me just put that in context for folks so that they can understand exactly how extraordinary this is. In June of 1980 was the first time that we heard about the HIV vaccine. The first AIDS cases were reported. 4 years later, the actual virus was identified. So that was in 1984. A year after that, 1985, a diagnostic test was created. And 35 years later, we still don't have a successful phase 3 vaccine trial for that virus. We found out about the first case of COVID in SARS-CoV-2 in December of 2019. So it's just about a year ago, at the end of the month of December. Less than a month later, in early January, the SARS-CoV-2 virus was identified. Less than a month after that, the first diagnostic test was developed. And 10 months later, we've had 2 successful phase 3 vaccine trials. So it's really extraordinary how the science has developed over this period of time. And I can tell you, for me, it spans my career in medicine, because I was graduating from medical school as HIV was being diagnosed, and now, just many years later, have the great privilege to lead our medical school. So I've been asked to do a couple things. First, to talk about the different kinds of vaccines so that folks get a sense of the science that's being involved. Many people are wondering, well, which vaccine do I want to get, and which one is the best for me? And I'll answer that question by saying the best one for you is the one that you're able to get. And I'm sure Commissioner Cranston will talk about that just a little bit later. Let me start by talking about the vaccines that are made from nucleic acids. So we all learn in 8th grade biology about RNA and DNA. Both the RNA and DNA are being used to develop vaccines. Let me talk about the messenger RNA vaccine, because that's the one that's sort of present in most of our minds, because that's the Pfizer and Moderna version. And so all of us have messenger RNA in our cell and working in our bodies every day. What's happening here is that messenger RNA is being delivered into the body by a lipid particle. That's why we have the cold chain. We can talk about that in a little bit. So you wrap messenger RNA in a lipid particle. The lipid particle adheres to the cell. Then the messenger RNA is brought into the cell. It stays in the cytoplasm. Some people say, well, gee, is my RNA going to be changed, or is my DNA going to be changed? It's not, because it never gets into the nucleus. In the cytoplasm, so in the non-nuclear portion of the cell's mechanisms will incorporate that messenger RNA, and the messenger RNA will send a message to the cell. And in the ribosomes, it will tell the cell to make the spike protein of the coronavirus vaccine. So just think about that. We've all seen the picture of the coronavirus. We know that the spike comes off the cell. The messenger RNA is going to tell our cells to actually make some spike protein. And then the cells go to work. It eventually exudes that spike protein, puts it on the surface of the cell. And when it's on the surface of the cell, our body says, we're not used to coronavirus spike protein. And so it actually attacks that cell. And when it does, it then sets off the immune mechanism in our bodies to create memory. And so the T cell, there are T cells and B cells. That's perhaps more detail than we need, but those cells will then work to create memory so that we maintain, our bodies remember if we were to see that spike protein. So now, if we're with someone and for some reason we get the coronavirus, the body will look at that spike protein and say, that's not supposed to be here, and will attack it. Now, we don't have to worry about the fact that the messenger RNA came into our body, because the body is smart enough to say, well, that messenger RNA isn't needed anymore, and it actually lets it go. So that's one kind of vaccine there, and those are the Moderna vaccine and the Pfizer BioNTech vaccine. If you wonder, like, where have we seen this before? Vaccines to HIV and Zika, or the DNA for the West Nile virus in horses is an example of a DNA vaccine. Okay, now, then we've heard a lot about AstraZeneca and Johnson & Johnson, Janssen, or the Merck vaccines. They are viral vector vaccines. So let me just talk a bit about the AstraZeneca vaccine, because that's the one that people are hearing a lot about. That actually uses a vector. So in this case, it's a chimp adenovirus. So it's an adenovirus found in chimpanzees. So it's not native to the human body. And think of the vector like an envelope, and it's actually going to deliver into the cell the protein it's going to deliver into the cell the instructions to make the spike protein. So it uses this harmless virus. It's similar to a common cold virus, and that then delivers the genetic codes into the cells, again, to produce an antigen, in this case, spike protein. So and then the mechanism is quite simple after that. Once it's produced it, then those spike proteins get on the surface of the cell, and by being there, that produces an immune response. We can talk a little bit, if you'd like, about that vaccine, and it's had some challenges in its process of being developed, and we can talk about that perhaps a little bit later if people would like to do so. AstraZeneca hopes to make 300 million doses of vaccine, and Johnson & Johnson, which is using a similar version, hopes to make 1 billion doses in 2021. So we're hearing a lot about Pfizer and Moderna at the moment. It's quite possible that into our lexicon will come AstraZeneca, Oxford, or Johnson & Johnson, Janssen into the new year, because they'll be making, right between the two of those companies, 1.3 billion doses of vaccine. Then there are, and if you're wondering, like, well, where have I seen that before? The Ebola virus vaccine, the measles vaccine, the vaccinia vaccine, these were the kind of vaccines that use this technology. Okay. Then there are whole virus vaccines. And you've heard about this some if you're following the development of the Sinovac vaccine in China. That's now been improved. In fact, I was talking with some folks yesterday from Abu Dhabi, and the Emirates have now approved the Sinovac vaccine for use by the people there. And what that does, that uses a weakened form of a virus. So the virus is weakened so that it can't cause illness, although it could cause illness in some folks who have weakened immune systems. So if you have another kind of a disease, and so there's often caution given those. And what this weakened virus does is it triggers an immune response. In an otherwise healthy person, a live attenuated vaccine, like the yellow fever vaccine, the polio vaccine we all took, the measles vaccine, these are live attenuated vaccines. They work with the body to say, okay, we've seen this weakened form of the virus. Then when we see the strong form, we're going to go after and get it. And then there's also an inactivated vaccine. So that we could weaken a vaccine, or we can take a vaccine and in the laboratory, we can inactivate it. And that's the one we know most about. That is the influenza vaccine or the hepatitis A vaccine. Similar case. We take pieces of genetic material that are foreign to the body. It brings those are incorporated into the cells, and then when we actually see the vaccine, the coronavirus, we actually attack it. And then the last one, the last of the 4 major categories, is a protein subunit. And there, what we do is we take a small piece of the pathogen, not the whole virus, which we weakened, not a virus that we've actually taken certain genetic materials of, but we've taken a small piece of it. And those fragments are incapable of causing disease, but they are capable of stimulating in our body an immune response. So we've been quite advanced in our laboratories across the globe. Right now, there are 154 vaccines across the world being explored. 21 are undergoing safety tests in phase 1, 13 in phase 2, and we've had 10 in phase 3. And that's your primer on vaccines for today. I'll look forward to answer some of the questions a little bit later. Thank you.
Thank you, Dr. Collins. Appreciate that. Very useful information, and appreciate you doing that in a condensed period of time. Commissioner Cranston. Oh, there we go.
I promised I would unmute before I said good morning, and I didn't do it. Good morning, everybody, and thank you for your time and your interest today. Thank you to Brooke and AIM for inviting me to participate in this panel, and thank you, Dr. Collins, for a very cogent and concise summary of some deep, deep science. You and I share, I think, common historical periods in that we both remember the early days of the HIV pandemic. This is my 3rd pandemic, having also lived through H1N1, which was was successfully managed through a vaccination effort. But boy, do I wish we had an HIV vaccine after all these years. But yesterday was a really important day in the United States and in Massachusetts, and for all of us, as the first doses of the Pfizer vaccine were confirmed, delivered, and started to be administered in Massachusetts. I am very excited about the range of vaccines that will ultimately, we anticipate, be available. But we are working strictly with those mRNA vaccines at the moment, the Pfizer, and ideally and hopefully by the end of this week, we will have approval on the Moderna vaccine. Something that you probably are aware of, and it just needs to be reiterated, is they have very different storage and handling profiles. The Pfizer vaccine is first out of the gate, but actually is the most complicated vaccine to manage, and therefore is being prioritized, particularly for clinical settings. The Pfizer vaccine needs to be stored at a term we've all learned, ultra cold freezer temperatures. That's -70 degrees Celsius. That's over 90 degrees, -90 degrees Fahrenheit. That is the temperature of dry ice, an extremely cold temperature. And only specialized environments usually have, the clinical and research environments generally have these ultra cold freezers that can maintain these vaccines at that temperature without special containers. They are coming in special containers that have pelletized dry ice in them, and they're coming in fairly large dose quantities. The smallest quantity of they come in small vials, 5-dose vials, but those they come in these boxes that are 195 vials per, which is 975 doses, and in turn 5 of those boxes go into these special coolers. So I'll walk through our prioritization, but really for these practical considerations, generally speaking, the Pfizer vaccine is going to hospitals and health centers that can manage this level of cold chain. You cannot lose the temperature. You can't have an excursion from the temperature range that these vaccines need to be held at for even a brief period of time, or else they become invalid and need to be destroyed. Every dose of this vaccine is precious, and we want to, at the end of this, look back and say we didn't lose a single dose of vaccine. The Moderna vaccine is much easier to handle. It can be stored at longer temperatures at longer periods at normal freezer temperatures, and can be refrigerated for up to 30 days. The Pfizer vaccine, once thawed, has to be used within 5 days, and it comes in smaller quantities, 100-dose quantities. So it's going to be much more suitable for smaller clinical environments, for the use in vaccination clinics, where you don't need the same level of specialized handling and equipment and freezer capacity to manage it. So we're very eager to have the Moderna vaccine available. And while we don't have all the details on the other vaccines, we do expect them to be much more readily handled, not unlike the Moderna vaccine. So last week, Governor Baker did announce our phased approach, and if you go to the mass.gov website and just put in COVID vaccine, you'll get to our website, and you'll see our prioritization process that has been laid out with the assistance of a blue ribbon external COVID-19 advisory group that worked for 2 months, meeting on a weekly basis for several hours at a time. And these are clinicians, researchers, community health specialists, representatives of the religious community, of the local health community, that really wrestled with some of the information we had from national bodies that had made recommendations, like the National Academies of Sciences, Engineering, and Medicine, as well as the CDC's Advisory Committee on Immunization Practices, and adapted those prioritizations to meet Massachusetts needs. They held up 3 core principles in prioritizing who gets the vaccine in what order, because we are in a situation where at the beginning, the vaccine is essentially coming in a trickle. We got our first allocation of the Pfizer vaccine starting yesterday, and the rest is rolling out today and tomorrow. That's only 59,000 doses for the entire Commonwealth. And so we had to make prioritization decisions as these vaccines trickle out. We expect about 300,000 doses of vaccine, both Pfizer and Moderna, by the end of December. And then an expanding cone of availability, both for those two vaccines and ideally for the other formulations that Dr. Collins reviewed. And then we will have millions of doses of vaccine available in due course. But in the early days, we really need to make sure we're achieving some core principles. The first and foremost being preventing serious illness and complications of COVID-19 infection and deaths that have associated. We're in the middle of a surge. I don't need to tell anybody. We're in the middle of a serious surge of COVID-19 infections, and seeing 4, 5, sometimes even 6,000 cases per day being reported in Massachusetts. Happily, due to improved treatment science, we're not seeing the same levels of death associated with COVID-19 infection as we saw at the very beginning, particularly when it was impacting people in nursing homes and other long-term care facilities. But nonetheless, we are still seeing, unavoidable deaths every day. So one of our first priorities is to reduce the number of complications and deaths associated with COVID-19. We need to preserve, and this is tied to that first principle, preserve the healthcare infrastructure and make sure that the clinicians and other healthcare workers supporting people with severe COVID-19 illness are able to go to work, and those institutions are able to meet those needs. And a co-equal principle is achieving health equity. First of all, we recognize that COVID-19 has not impacted all communities equally, and some communities, in particular communities of color in Massachusetts, have had an undue and disproportionate impact of COVID-19. And so as we roll out the vaccine, we not only don't want to exacerbate health inequities, we actually want to correct them. We actually want to reduce health inequities by making sure the vaccine gets equitably to all communities impacted by COVID-19. I'll walk very briefly through the 3 phases of rollout. Phase 1 is generally between now and we anticipate about the end of February, where we are first prioritizing clinicians and non-clinical healthcare workers doing direct COVID-facing care. This includes individuals doing environmental services, food service, other support services in clinical environments where people with COVID-19 are most likely to be receiving care. Immediately after and starting very, very soon through a federal partnership with the pharmacy chains CVS and Walgreens, long-term care facilities will be next in line. This includes nursing homes, assisted living programs, rest homes. These are the congregate living environments where some of the most vulnerable individuals are living, and where we have seen significant outbreaks of COVID-19 from the beginning of the pandemic. First responders, including police, fire, and emergency medical services staff, also seen as COVID-facing professionals in need of protection from the virus and able to perform their important work, are third in line in phase 1. Then followed by other congregate care settings. These are group homes, shelters, correctional facilities, other places where people must live in group environments where we have seen significant outbreaks of the virus that can also prompt outbreaks in the larger community. Home-based healthcare workers are prioritized also in group 1. These individuals are home health aides and personal care attendants who are providing care in the home to people who are at risk for COVID and who are vulnerable to COVID. And then finally, the rest of the healthcare workforce are prioritized for phase 1. So that's a lot of individuals to get vaccinated in a relatively short period of time, but it's absolutely tied to those 3 principles. In particular, making sure individuals who work in these various industries, who are from communities and both geographic and cultural racial communities, who are more likely to be working in some of these areas. I'll call out home health aides and PCAs in particular, have equal access to the vaccine. In phase 2, we move to populations, individuals who have higher medical risk of acquiring COVID-19 and having severe complications. First, individuals with 2 or more comorbidities. These are serious medical conditions like cancers, respiratory conditions, diabetes, that have been shown to be implicated in higher risk of COVID-19 complications. We have a long list, and this will be of particular interest to AIM members, of industries and work areas that are considered critical areas, not exactly lining up with the essential worker list, but overlapping with it, of critical areas from the maintenance of a fair and open democratic society. This includes education workers, both early education and K through 12, people who work in transit environments, grocery store workers, utility workers, people who work in the food and agriculture businesses, sanitation workers, public works workers, and people in the public health infrastructure. After that group, and I recognize it's needing additional articulation and clarification. We get a lot of questions about who fits into which category, and I'll give you some instructions about how to submit some guidance to us, or some recommendations to us. Then adults over 65 are prioritized, and then people with one of those comorbidities. And that phase is between February and April of 2021, ideally. And then starting in April, the rest of the population, which is about half of the Commonwealth, become eligible for the vaccine. And that process is going to extend until June. While much of this work is initially going to happen in healthcare settings and specialized settings and specialized clinics for some of these professions, increasingly we're moving into a mass vaccination framework. We'll be relying on all hands on deck: pharmacies, local health departments, business-based clinics, as well as these mass vaccination clinics you'll be hearing more about, that will be able to handle very high throughput. If you have questions about sort of where do people in your industry fit, I direct you to the mass.gov website and the COVID vaccine website. Where can I get vaccine? And there's an email in that website where you can submit your questions or concerns or recommendations about where you think your industry and your workers best fit. And that will inform a twice-a-week process of updating our website with further clarification. We're learning a lot about how people see their workers in terms of their eligibility under this existing broad framework, and we want to get as granular and precise as possible so that you know when you and your workers are going to be eligible for vaccine. I think I'll leave it at that, Brooke.
Thank you, Commissioner. That was incredibly useful information, and appreciate those references to the website where people can find more details. I'm going to move on now, and Maura's going to speak to the employer side, which I know many of our members are eagerly awaiting. So without any further ado, Maura, take it away.
Thank you, Brooke, and thank you, Dr. Collins and Commissioner Cranston. As the non-scientist here, I feel this was incredibly educational, and I've just heard the word RNA more than at any time since 10th grade. So in the employer world, the basic thing we all know is that there's a lot of uncertainty right now. We absolutely expect additional guidance. This is not only in terms of the science, as the other panelists have said, but in terms of the legal and regulatory framework and the guidance. It's a rapidly moving world, and we do expect to hear more. Right now, the EEOC and CDC both recommend encouraging employees to be vaccinated. We don't hear anything more specific, but we absolutely expect additional guidance. Until we do hear more guidance, what we can focus on in the employer community is the need to be thinking about requests for accommodations from employees who ask to be exempt from any vaccine requirement for disability and religious reasons, the effect of the emergency status on the vaccine on any requirement an employer might want to put in place about employees getting vaccinated when, of course, the time comes that that's even a possibility, and general safety considerations under OSHA and otherwise. Many of you on this webinar have already had one or more experiences with the idea of accommodation, But the basic premise under the Americans with Disabilities Act and Title VII of the Civil Rights Act and their state counterparts under Massachusetts law is that employees with disabilities or sincerely held religious beliefs that would prevent them from taking any COVID vaccine may be entitled to an exemption unless there is an undue hardship. A reasonable accommodation is a change in the work environment that allows an individual with a disability or with a religious belief or practice that conflicts with work duties to perform the essential functions of the position. I'm speaking about all of this at a very high level. Again, any of you who have touched on this issue at all know that each of these has a whole rabbit hole of analyses you can go down. But just as the other panelists did, giving a high level view. So once an employee raises a sincerely held religious belief or disability issue, the employer has to have an interactive discussion and see whether an accommodation can be reached. Employers don't have to grant a request if, even with the request granted, the employee can't perform the essential functions of the position, or the requested change poses an undue hardship to the employer. What's an undue hardship? It can be present when the requested accommodation results in significant difficulty or expense for the employer, or where it is unduly disruptive or would fundamentally alter the nature or operation of the business. So you might imagine that these are very different analyses in the sort of healthcare environment that have been discussed as getting the vaccines first versus maybe something in the middle where there's a lot of public facing like retail versus employment situations where employees can work with very little interaction or exposure to the public. With respect to disability accommodation and seeking exemptions from any vaccine requirement an employer might want to put in place, the types of conditions we can expect employees to bring forward would include things like chemical sensitivities, allergies, stress and anxiety, breathing issues. These are the sorts of things we've seen in court cases which have challenged required flu vaccine programs and other vaccine programs. When the employee brings forward a request for an accommodation, this triggers a duty on the employer's part to have an interactive discussion with this employee about whether there's any accommodation that will let the employee do the essential functions of their job. It is going to be tempting to want to skip that sort of back and forth in these situations, which can be time sensitive and which can bring up heated emotions. Don't skip that. That is where claims get started. Even if the requested accommodation of remaining in one's position without taking the COVID vaccine isn't reasonable or is an undue hardship, you may need to consider whether some other accommodation could be reasonable here. For an employee who declines a vaccine, depending on the circumstances, appropriate accommodations could possibly include modifying those non-essential functions of an employee's work duty. If an employee raises an objection to one type of the vaccine, in some cases we've seen with other vaccines concerns about animal-based products, maybe taking an alternative version of the vaccine. I don't even know if medically that's going to be an issue here. Having the employee wear masks and face shields and engaging in the other protective measures that so many employers currently have in place. Transferring someone to a vacant position that might not need this, or a leave of absence. Once the accommodation's in place, you can keep working and checking to make sure it remains effective. As we've talked about, this is an incredibly fast-moving scenario. What the workplace and the world around the workplace look like will be different day to day, week to week, and you can continue monitoring it to see if this is still effective in keeping the employee doing the job and keeping the workplace safe. Of course, there's a need for medical certification for any request for an accommodation of this sort, and if an employer if an employee doesn't cooperate, they may not be entitled to the accommodation. This same accommodation framework comes up in religious accommodations. But before we talk to that, I just did want to touch on this idea under the Americans with Disabilities Act of direct threat. Generally, the ADA prohibits employers from excluding individuals from the workplace for health or safety reasons unless they propose a direct threat to the health and safety of the individual and others. Direct threat is a risk of substantial harm that can't be reduced or eliminated even with a reasonable accommodation. In March of this past year, the EEOC found that the circumstances at that time regarding COVID showed that yes, it would be a direct threat. It would be a risk of substantial harm by having somebody with COVID-19 or with symptoms of it present in the workplace. So we're waiting to see what additional guidance the EEOC may give us about having unvaccinated employees in the workplace when and if we get to a time where the vaccine is widely available. For religious accommodation, it's very similar to disability discrimination. Once an employer has noticed that an employee's sincerely held religious beliefs or practice or observance prevents them from taking the COVID vaccine, the employer has to provide a reasonable accommodation unless there's undue hardship. Sincerely held religious belief is a delicate concept. Generally, we don't look much into what an employee may sincerely believe, but the EEOC has found that some factors and some circumstances might call into question the sincerity of the belief, and just a matter of preference or opinion or feeling isn't enough. Definitely an area in which to tread carefully. The undue hardship standard is a little lower in a religious case than in a disability discrimination case. And things that might be relevant to an undue hardship analysis would be an assessment of the public risk posed at a particular time, the availability of alternate means of infection control, and possibly even the number of employees who are requesting such an accommodation. Because we're short on time, I just want to touch briefly on two other things employers may wish to watch, but we don't have definite answers for. One is whether the fact that vaccines are approved under the emergency use authorization procedure has an impact on whether employees could say no if they wanted to. The fact sheet that's being handed out now with the Pfizer vaccine, if I understand correctly, says, what if I decide not to get the vaccine? It is your choice to receive or not receive. We don't know what impact that's going to have, but employers should know that that's floating around out there. And then generally the idea that OSHA has a general duty of safety clause requiring employers to provide a workplace free of recognized hazards that are causing or likely to cause death or serious physical harm. OSHA has not yet provided guidance on COVID vaccines. In the past, it has said that employers may offer or may encourage vaccines, but in light of the general duty clause, employers should keep up their other protective measures until it's safely determined that letting these fall away doesn't create a safety risk. And with that, I'll turn it back to you, Brooke.
Thank you, Maura. Appreciate that. Again, as with the other panelists, covering a lot of information that's very technical and detailed in a short period of time. This leaves us about 20 minutes for some Q&A, which I know I can see we've got questions coming in. We had questions submitted in advance from some of you who registered. So with that, I'm going to start by posing a question to Dr. Collins. While it's exciting that there have been at least these first three that we've discussed, vaccines from 3 different pharmaceutical companies that have already either been proven effective or close to FDA approval, what you stressed was that we need to remember that it is a daunting task to vaccinate not only the entire state, the entire country, but the world as a whole. All we keep hearing lately, particularly if we watch the news, is that the vaccine means that we're close to the pandemic being over. So the question I have is, when can we get back to normal? In your assessment, what does that timeline look like? And if the pandemic will not be vanquished soon, will businesses continue to be challenged? And what do they need to do?
Well, I think that all comes down to what your definition of normal is. I'll tell you what how I think things are going to play out, and then you can determine whether that's your normal or not. If you're asking about masks, I think we wear masks into 2022. Now, why do I say that? We're going to start vaccinating the people. We really need to get to 70 or 80% of the population, somewhere in that percentage, in order for us to get what's called herd immunity. So let's just think about America for the minute. We've said, if you look on the TV, it says 15 or 16 million people have gotten it. Let's say it's off by a factor of 3. So let's say 50 million people have gotten it right now. And now we're going to start to roll out vaccinations. Until we get to 250 million people vaccinated or have had the disease, we're not going to be at herd immunity. And so that's just a reality, and it's going to take us a bit of time to get there. I'm a little less worried about some of the rules and laws and things like that at the moment, because we don't really have ample vaccine for everybody who wants to get it. I think we can spend a lot of time between now and the summer getting people vaccinated. Now, that said, a couple things. I think it could be a little more normal next summer. If the virus goes kind of like we saw it last year, where when people go back outside, we see less virus load, we see less disease. You've been vaccinated. I think there'll be an opportunity for you to feel a little freer. I also think there will be better testing then. Quite possible that you'd have a little device even right next to your coffee pot, where you would put some saliva in that in the morning, you'd push the button, and by the time the coffee's done, you would know that that you're COVID negative for the day. I think that would give you a certain amount of freedom. What we don't know, two things we don't know. We don't know whether the vaccine is going to prevent disease or whether it's going to diminish disease. And it's possible that if you get the vaccine, you might still be able to shed virus, which is why you're going to continue to wear the mask, even though you've had the vaccine. And the second thing we don't know is how long the vaccines are going to last. All of us would love to be able to say, it's going to last forever, or it's going to last for 4 or 5 years. What we know, based on the data that exists right now, which is a couple of months of data, we know that it's fairly effective right after you've been given it. The trials are 2-year trials. So it's not until those trials are done, a year and a half from now, are we going to know the final data. And just think about the flu vaccine. You've got to get the flu vaccine every year. And it's possible that we may have to get a coronavirus vaccine again sometime next year. So those are things that we're going to have to factor into. And I think that all of us need to be very humble about making absolute statements at the moment. Because this virus, I don't know if you read, but there are some new variants in England discovered last night. We don't know whether they're more virulent or not, but right now we're dealing with a single serotype virus, and if the way viruses replicate is they like to change their nature a little bit so that they can continue to be virulent, and so we don't know whether that's going to, no evidence of that happening at the moment, but that's another thing we're going to have to watch. If I might just add one more thing. If you haven't gotten a flu shot, you should get it. And now's the time. Don't wait anymore. One thing you can do to help, because the symptoms are often the same, is to go out and get your flu shot. We're not seeing a lot of flu at the moment. There's some, but there's not a lot, because people are wearing their masks, washing hands, social distancing, and getting a flu shot. So if you can get your flu shot now, the arm will be good and ready for when the coronavirus vaccine becomes available.
Thank you, Dr. Collins. That was very helpful. I'm going to ask you one follow-up because you mentioned it in your answer, and we have received this question. You mentioned that some of the questions that still remain about how effective and how long the vaccine will last are still uncertain because trials are still ongoing. To that end, does the fact that quick approval happened for these vaccines in any way make them less safe or did they skip any of the traditional tests that they needed to go through in order to make it to this point in the process?
No, I don't think that the speed of the approval, if you think it was speedy, has any bearing on the safety. Science has just advanced to the point. You know, we've been working on messenger RNA vaccines for about 10 years. We didn't have one that worked, but we've been working it. So the theories behind it are fairly well known. But you can see, I tried to make the analogy early on to the HIV virus, because you can see how quickly, you know, compared to HIV, that we've been able to understand the genome, you know, make vaccines against them, and multiple kinds. And we're going to need multiple kinds around the world. We're not going to be, not everyone is going to be able to have, you know, just think of how many places in the developing world have refrigerators that can hold the vaccine at -70°C. And so we're going to need these other vaccines in order to get to the developing world. I don't think the speed, if you want to call it speed, has anything to do with the safety and effectiveness. And I can assure you that I will bear my arm as soon as my number comes up on the vaccine order.
Thank you, Dr. Collins. That was very helpful. And I think particularly your discussion around what we need to do in the interim while we wait to get to this position where we do have herd immunity with respect to wearing masks, distancing, following some of the health protocols that have been put in place is important, particularly for businesses as they're, you know, bringing in members of their workforce or even interacting with members of the public. I'm going to switch over and actually pose a question to Commissioner Cranston. Commissioner, since the announcement last week of the state's distribution, or as you referred to it, the prioritization plan, AIM has received dozens of inquiries and questions around whether there is flexibility with regard to which industries have been designated to receive the vaccinations and when. I appreciate that you went through what the phased approach was and the rationale behind it. But I will give you just an example. One of the questions we heard was around who's considered an essential business. And if you remember, this was a designation that was used quite frequently as it related to the state's reopening plan. And so there have been a lot of questions about what really falls into that definition of essential, and based on you know, people's interaction with the public or what they do on a day-to-day basis, is there some of that flexibility with respect to what this distribution plan looks like? Can you speak to that a little bit?
Certainly. Thank you, Brooke. And I just want to thank Dr. Collins for reinforcing flu shots. And thank you for the public health message as well. I would less call it flexibility than call it a need for clarification and specification. The advisory group that advised Governor Baker was very precise in its overall characterization of areas. And again, I said earlier, we try to separate the language of essential worker or critical worker, mainly because those lists are not identical from what was used during the shutdown and reopening process and what's being designated for vaccination prioritization. But the concepts are overlapping in terms of these are areas of work and industry that are seen as essential for maintaining a functioning society. And that's really the framework that went into putting that list of work areas into the phase 2. What I would say is, and Brooke, I sent you the email that we are accepting questions and requests for clarifications, and perhaps AM can send out that email to your members, because that's, I think, the best way for you to get at both at an individual industry level, but also for all of us to get the optimal clarification and the level of granular information that clearly folks need to plan for this next phase, is to send your question or concern or your recommendation to that email, and that will inform. We're meeting twice a week with our clinical advisory group and with senior leadership in the administration to say where does this person fit. I'll give what I consider an easy example. Is we got a question from the hospice and palliative care industry asking where do their workers fit. And it seemed pretty clear to us from their articulation that they fit in the COVID-facing healthcare category because of the many individuals who the hospice and palliative care industry is working with are COVID positive patients. And therefore that's an easy determination. I'll give another one that was is taking a little more thought is, where do convenience store workers fit? And the articulation that came to us from the industry is that they fit under grocery workers, that the convenience store industry serves as a primary grocery store outlet, particularly in certain urban and frankly rural environments where they are the most convenient area outlet for essentials like milk and eggs and bread. And so those are the kinds of considerations that we need to wrestle with, taking the broader categories and then fitting additional specifics into those categories and explaining why that's the case. So utilizing that email and trusting our process for reviewing those and posting those on our website in a rolling basis, probably about twice a week, we'll be updating our website with that information.
That's fantastic. And we will absolutely share that email with members here today who attended. They can utilize it. That's very helpful. Maura, switching over to you, and I'm going to ask a question that you already covered, but because we get it so frequently, and I know you get it, I just want to put a fine point on it. So the question is, can employers require vaccinations as a term of returning to work from their employees? What do you have to say for all the folks who have that question out there?
So the answer is, we don't know as a solid answer yet. I will say the guidance we've had in the past has said you've got to at least consider these ideas of reasonable accommodation and undue hardship. Those two things may mean something different in this pandemic world, or may at least take into account different considerations than they did a year ago today. But right now, employers should be thinking about it in that framework, the idea of possibly having to offer an accommodation. What employers can require, though, is screening, temperature taking, fitness for duty, COVID tests. Right now, the EEOC has said that under currently existing circumstances, because of this direct threat idea that we talked about, an employer can bar an employee from physical presence in the workplace if they refuse to have their temperature taken or refuse to answer questions about whether they've had COVID-19. And while it doesn't directly address the idea of testing itself, when you read all the EEOC guidance together, I think I'm pretty strong footing to say that the testing is probably legit. And so, and again, the guidance that we've gotten is that, try to get cooperation, right? If you hear an employee who doesn't want to give you information, who doesn't want to tell you if they've been exposed or have their temperature taken or take the test, see if you can figure out what the reluctance is. Are they afraid that the information they're giving you won't be kept confidential, etc. But right now, we don't have a 100% solid answer on, can we require a vaccine? We do know that there's a lot we already are doing and can do to keep workplaces safe. And for now, particularly in light of all the other information we've talked about today, those are really good practices.
That's a great point, Maura. And I will say, both you referencing everything employers have done and the importance of testing, as well as Dr. Collins referencing the importance of testing, right, in this period. A follow-up that I want to ask is, while we are on this path of moving towards getting people vaccinated, in this interim period, the role of testing in 2021 is going to be critical for the business community. And so, are there any sort of lessons learned or best practices from the testing side as far as what employers have already done to keep their places of work open and safe, that you can say, keep those going or do, X, Y, and Z into 2021, again, while we wait to see if we can reach that herd immunity status?
Was that to me again?
Yes, sorry,
Oh,
Maura.
I'm
Yeah.
sorry, yes. Oh, I mean, look, the sector-specific guidance that's come out from the state should be referenced, frequently and carefully by employers. There, it is, everything that employers have been doing, and I know it varies from sector to sector, industry to industry, but look, the whole idea of the very basics, having employees self-certify that they are not exposed to anyone who's had COVID, that having them take temperatures or having a mechanism to take temperatures. Some large office buildings have it sort of right at the front. Other places have worked out the system that works for them. But absolutely, self-screening, all the things that we've talked about, the little details, keeping people far apart, having one-way traffic, even in an office space where you never thought about having anything like that before. Definitely, it sounds so simple to say, the hand washing, the reminders not to touch the face. I think recently we saw guidance or recommendations to, either close off or discourage break rooms in common areas. All these are, what we can do now, what we should do now to keep our employees safe and keep our operations functioning.
Thank you, Maura. I appreciate that. Dr. Collins, so a question, and I know this is something that's been something we've looked at AIM, but is a big part of what has been an impact from the COVID virus and the reductions or rollbacks of openings in the economy is that we've seen, kids either learning remotely or in a hybrid method, or maybe reduction in ability for kids to get into daycare. And what we've seen is that as it relates to the vaccines that are being discussed today, children under 16 are not approved to receive them. This is obviously significant because their safety is critical to getting schools reopened and the economy back on track. Can you speak to why, that segment of the population isn't included, and how nevertheless, we're going to be able to get to where we need to get based on, the other populations that can be inoculated?
Yeah, I think the answer is yet. And what the reality is that the studies that were done, particularly Moderna and Pfizer studies, were done in research subjects 16 to 91 in the Pfizer category. And we just don't have the data yet on children, similar to women who are pregnant or mothers who are lactating. There is guidance on that, which is you should have a conversation with your practitioner, but it's been approved for individuals older than 16. We don't have data yet on pregnant women or lactating women, but it is deemed safe for them. We have no data on children, which is why the recommendation at the moment is not to vaccinate children. Now, there's also a reality that children don't seem to be getting as sick. Now, if you've had a child that's very sick, that generality doesn't apply to you. But by and large, younger children, though they may be very large virus shedders, for whatever reason, don't seem to get very sick. And it'll be fascinating. I can't wait. If you want to invite me back 5 years from now, I'll be able to explain to you why that was the case. I have a lot of theories about it, but the reality is that there's so much about, we're 11 months into this disease. There's a lot we just don't know about it yet. And so because we don't have the data, that's the reason children haven't been included in the earliest phases of the vaccination. But the data is being collected. There are studies being contemplated, and hopefully before too long, the FDA will be able to consider children, and hopefully we'll have a vaccine that will work in children that we can then have them have.
Wonderful. Thank you. Appreciate that. I know we're running short on time, so Commissioner Cranston, I'm going to pose the last question to you, and I apologize. I'm not leaving you a great deal of time to answer it, but I think it's important. At AIM, we've remained focused on ensuring social and racial inequities are addressed in public policy matters related to employment. And I know this has been a priority for the governor as well. You mentioned in your remarks that a goal with respect to the distribution plan is achieving health equity. And so to that end, can you speak to the steps the state has taken to consider issues related to diversity, equity, and inclusion, and the need to provide appropriate education, but also access to some of these communities that maybe typically have been left out.
Big question, quick answer to hit on key point. Some of the professions that have been highlighted for priority is one of the ways to do this. We also are applying a social vulnerability and COVID impact index to our distribution or allocation plan. So after phase 1, communities that have been designated as high vulnerability or have had historic high impact of COVID will get additional allocations. We are very much relying on the community health center movement. We have a robust community health center system in Massachusetts, which has extraordinary reach into communities, both geographically, by culture, by race, by language. And we are ensuring that our communication strategies are both tested in and responsive to the languages, values, and frameworks of a broad variety of communities in Massachusetts. A very short answer to an important question.
Absolutely, thank you, and I appreciate it. We are at 10:30. We could talk about this for the remainder of the day. I want to just say a huge thank you to our panelists, Dr. Collins, Commissioner Cranston, Maura McLaughlin. I think you provided an immense amount of education in a short period of time. We will share the information that Commissioner Cranston referenced with everybody here today. I also want to just briefly thank all of AIM's sponsors. Without their support, we couldn't have put on a program like today. We will continue to follow this issue. We will continue to solicit feedback. I want to thank you all for taking times out of your busy schedule to do this, and please enjoy the rest of your day, and everybody stay safe. Thanks so much.
Thank you.
Thank you.
Nice to be with you.